Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. In lieu of doing an interview today, I'm going to do things a little bit differently, and I might do this from time to time. I haven't decided about how frequently yet, but I'm actually going to recycle material that I had done at a conference a few years ago. I had done a presentation for the Minnesota State Brain Injury Association conference back in 2019, and I had always been on my bucket list to do a state conference, and I got to check that off my bucket list, which was really exciting. But I only got to share the information with the people that attended that conference. I did then bring back that material and did the presentation again later in the year at a conference down in Wisconsin. But again, only got to share that information with those people. So I wanted to share it on a broader stage here. So here we are sharing this information from the presentation that I had done a few years ago. So I've tweaked it a little bit to make it a little bit more appropriate for a podcast rather than standing on a stage, since many of you will be listening and not looking at the pictures. So I described things more than using the pictures that I normally do. So without further ado, here is the presentation. The title of the presentation was Adding Insult to Injury When Stroke and Other Brain Injury Occurs Together. So the objectives of the presentation, as it were, again, differentiate brain injury versus stroke, identify the long-term consequences of brain injury versus stroke, discuss the cumulative impact of stroke and brain injury, and then discuss how other illnesses might impact those cumulative brain injuries. So when we have more than one happening at a time. So first off, let's just kind of talk for a moment about the definitions of brain injury and stroke and really identify what each of those things are. A brain injury, when we think about brain injuries, we often think about things that happen during sporting events, like a helmet hit in football or skiing into a tree for those people who are skiers, pole vaulting accidents when people are going up over that really tall pole and coming down and landing in the pit. That used to happen a little bit more often than it does now because of helmets, but again, still can happen. Falling off of a horse, getting a baseball bat upside the head, all those different sporting events can also happen via motor vehicle accidents, falling and going head over heels down the stairs. Even bumping your head on a car door or kitchen cabinet can cause a brain injury. So brain injuries in general can range anywhere from mild to severe. So very wide range in there. Regardless of the severity, brain injury is a leading cause of death and disability worldwide and accounts for about a third of all the injury deaths that we see in the world. Again, the targeted ones that are most commonly listed in the research include falls and motor vehicle accidents that I mentioned earlier, but also intentional self-harm and assaults. Those are also very commonly causing brain injuries. The effects of brain injury, again, depends on the severity, but they can last anywhere from a day or a few days all the way up to the lifetime of the person that sustained the brain injury. Now let's take a step different and talk about what a stroke is. The definition of stroke, it is whereas brain injury was a leading cause of death, so is stroke, but stroke is the 5th leading cause of death in the United States alone, the 2nd leading cause of death worldwide. So across the world, it's much higher in death rate than we see here in the United States. Regardless, it is a leading cause of disability, even if it does not cause the death of the person that experiences the stroke. When we talk about strokes, there are 2 main types. It can either be an ischemic stroke or a hemorrhagic stroke. And as I go through some of these definitions today, I will try to break things down for those of you that are non-medical, but not make it too down for the people that are listening that are medical based. So ischemic strokes, by definition, means that there is a blockage in a vessel. So there was a clot or a plaque that led to the blockage of the vessel. And by blocking that vessel, blood and nutrients can't get past that. And then we end up with an area of stroke around that blood vessel territory. Versus a hemorrhagic stroke is when we have a bleed into the brain. Most often that happens because of high blood pressure. So the blood vessel just can't take the pressure from that high blood pressure, or from an aneurysm, a weakened area in the blood vessel itself that may or may not have high blood pressure associated with it, but that vessel ruptures and causes a bleed into the brain. They look very similar. We treat them a bit differently based on whether it's an ischemic stroke or a hemorrhagic stroke, but that's kind of just the main gist of it. I think a bigger conversation could be held for another day on that as well. But stroke, again, is often thought of as an older person disease. We have always thought of strokes happening in the 7th decade of life and above. That's kind of always where we saw those strokes happening. We are seeing those ages creeping down, however, so that we are seeing strokes more commonly now in people in their 40s and 50s, where we didn't used to see that when I started in healthcare 20 years ago. Some of the major risk factors for stroke that we know of include high blood pressure, high cholesterol, diabetes, overweight and obesity, and tobacco use. There are many more than that, but those are kind of the top ones that we see. The effects of a stroke, again, the severity of stroke can range significantly. Some people will leave the hospital with no symptoms, and some people will have symptoms that last the rest of their life. So again, those effects can last a day or more, or forever for that person. We do see some age-related differences when it comes to brain injury versus stroke. The TBIs, traumatic brain injuries, happen most often in younger patients, and that's because of the types of activities that they do. They're more involved in the sporting events that tend to cause those traumatic brain injuries. But however, when we see those brain injuries happen in younger patients, we have more years of work that is lost, more potential income that is lost, potentially a bigger impact on the family because they might have young kids at home or they might be a kid themselves. So it's a huge impact on the family, not just the patient. That is the same with stroke also, but it's just a different degree. As far as the causes, we can see difference in causes based on ages, as I kind of briefly mentioned there too. In young adults, it is most often motor vehicle accidents that causes the brain injuries. In kids and the elderly, so the different ends of the spectrum, we see falls more commonly as the cause of brain injuries. When we have a brain injury that happens, so we talked about what happens with a brain injury when it was a younger person. We have more lost work, income, all of that. When it happens in an older person, we tend to have poorer outcomes. There's greater disability involved. The brain just can't bounce back like it could when we were younger. So we see more ill effects essentially because of that patient being older. Stroke, however, as I mentioned a few minutes ago, tends to happen in older populations. So we see it more often in older. We do see younger, and I will say the youngest patient I've ever taken care of that had a stroke was, can't remember if he was 2 or 3 years old, but it was a very young patient. So it does happen, but it's not something that we see all the time. However, so I mentioned we see those strokes in older populations. That age is coming down, partly because of those risk factors. So things that cause high blood pressure, high cholesterol, diabetes, and smoking, all of those things are happening at younger ages. Therefore, we see strokes happening at younger ages because we are all susceptible to those types of things. Stress is raising blood pressure. The way we eat, our standard American diet, and I'll take a kind of segue on that standard American diet. If you break that down, it's a sad diet. If we all follow the standard American diet, we will all have diabetes at some point. So just following that standard American diet that we typically do puts people at risk for having strokes at younger ages because the diet is not that healthy. It's touted as being healthy, but it's not really that healthy. So it puts us at higher risk for having strokes even at younger ages. As far as the long-term consequences, there are some things that we can see with either or both a brain injury or a stroke. And there are some that we just see more specifically with a brain injury. So some of those things that we can see with either brain injury or stroke would include epilepsy, so development of a seizure disorder, decline in cognitive function, and that can be loss of memory. It can be loss of the ability to concentrate on things, difficulties reading, difficulties doing multiple tasks, things that we are often required to do in our workplaces. We can also see, because of both of those, an increased risk for development of sleep apnea, because again, things are changing in our brain when we have a brain injury, whether that be a TBI or a stroke. Take a sip of water here, and I'll move on. Sorry, I'm not used to being the one talking all the time. Increased incidence with TBI then. With TBI, we can see an increased risk for Alzheimer's disease, for Parkinson's disease. And the biggest one I think about with that is Muhammad Ali, when he was boxing. All of those hits to the head, and eventually he developed Parkinson's disease. So that's kind of the big one that jumps out of my head with that one. We can see with brain injuries what we call metabolic dysfunction. Basically, the body loses its ability to appropriately metabolize vitamins, minerals, nutrients. We can see all sorts of different dysfunctions because of hormonal imbalances because of the brain injury itself. And then we can also see more psychiatric diseases that come up after a brain injury. Part of that is because of the location of the brain injury. So if someone has a frontal lobe injury, meaning the front of the head was damaged, we can see more problems with impulsivity, with even changes in personality. People might not be the same person after a severe head injury than they were prior to the head injury. So we can see that a little bit more often. With stroke, we also see things like depression, anxiety that we see with both, but those other illnesses like personality changes, really we see more often with the traumatic brain injuries. When we talk about healing after a brain injury, whether it be a stroke or a traumatic brain injury, the brain has to heal to some degree. We can't just go on with the level of damage that we have, and our body tries not to do that. So our body tries to correct itself. We have this term we call neuroplasticity, where the brain is able to kind of make new connections and make new ways for the brain to actually do things, new ways to do the functions that the part of the brain that was injured needed to do. We do that by various techniques. One of them is an increase in the activation of stem cells in the area. So as far as stem cells, we've heard probably lots of different things about stem cells throughout the years. As adults, we do still have stem cells in our body, but they're very limited in where they are in the body and what they can do. Whereas when we're developing, we have all of those stem cells that can create any cell in the body, and they do. They create every cell necessary to maintain a human body. As we become adults, we have very few stem cells. We just have a fraction, like a 2% of the stem cells that we had when we were infants. And they're very limited in their function. However, when we have a brain injury, those stem cells get activated so that they try to regenerate some of that area. It's not always super helpful. And if you have a massive brain injury, they're not going to be able to regenerate the brain back to what it was before. But we can definitely get improvements, and that's where we see people improving after a brain injury and after a stroke. Another way that we have neuroplasticity is what we call angiogenesis. That's the creation of new blood vessels. Basically, when I've been working with patients in the hospital and they come in with an acute stroke, meaning they're having something right now, we look at their blood vessels and we look to see, do they have what we call collateral blood flow? So older patients have this better than younger patients. But we have this ability to create new blood vessels around an area so that we still get blood and nutrients and oxygen and everything to that area, but it might not be from that main blood vessel that initially went to that area. So we have this creation of new blood vessels, and we can do it after an injury, even in young patients as well, but it's great and it saves us so much when it happens, when we can see that in an older patient so that we have that to rely on in our brain healing. The last part of a neuroplasticity is the activation of what we call the peri-infarct zone. This is the area that surrounds that area of infarct, the area of the stroke. So that tissue around it gets activated, and how I describe this to my patients is those cells take on a part-time job. So they have their full-time job. They have their full-time job for the role that they were created to play. But in the process of healing, where our brain is healing from a brain injury, from a stroke, we are activating those cells to take on a part-time job so that they can do the things that the damaged tissue should have been doing. That will come up important in just a moment, however. So that's after a single insult. So after a single insult, the brain tries to do all of these things to improve and repair after the brain injury. There's a huge role for all of these things, especially that last part where we activate different parts of the brain to create new connections in there. Therapists, whether it be physical, occupational therapy, or speech language pathology, they all have their role based on what injury the patient has, whether it be a traumatic brain injury, a stroke. Those therapists will help to create these new connections and get us back to a healthier place. So what happens if we're trying to heal after multiple insults? So somebody's had multiple strokes, or they've had brain injuries and strokes, and regardless of what order that happens. When you have multiple insults to the brain, it takes longer to recover. Often patients don't get back to that original new baseline that they had. So after a brain injury, they get back to a new baseline. They create a new baseline. They may or may not get back to what they were before that brain injury, but they create a new one. And when they've had multiple brain injuries, that new baseline can shift from time to time. So we don't necessarily get back to what we were after that first injury. We can see progressive cognitive deficits, meaning again, poor concentration, lack of the ability to multitask, lack of the ability to just remember things from day to day. That becomes a progressive problem for patients after multiple injuries to the brain, regardless of where in the brain the damage occurs. And that thing I just talked about with the brains taking on the part-time job, when something else happens, it's going to set the brain back. That part-time job has to go away because the person needs to focus on their full-time job. The cells need to focus on their full-time job. So they might have some of those symptoms come back because the brain is trying to heal from this new insult that happened, and it can't do the full-time job and the part-time job. So it's got to take a step back and just do the full-time job, if that kind of makes sense to you. The next thing I want to talk about is when I did the presentation, it was a little image of a chicken and the egg. Which came first, the chicken or the egg? What happens when we have a brain injury and then a stroke, or a stroke and then a brain injury? So there is an increased risk of each other happening after one of them. So not surprisingly, patients are at an increased risk of traumatic brain injury after a stroke. Because of weaknesses they might have, they're at increased risk of falling. Because of their symptoms, maybe they have new chronic pain that they have because of the stroke. They now have multiple medications that they're on, treating the different risk factors, might be on sedating medications, treating their pain. That puts them at higher risk for falls and other injuries. And then some people, because of depression, because of the limitations that they have after their stroke, might have injuries because of self-harm. So that's not entirely surprising to see that happen. What tends to be surprising, however, is the increased incidence of stroke after a TBI. So after somebody has a brain injury, they're at higher risk for having a stroke. And in all the research that I was reading in preparation for this presentation years ago, there was no exact mechanism identified. So we can't say why this is, we just know that it's there. So therefore, this leads to brain injury being another risk factor for stroke. So we talk about high blood pressure, high cholesterol, diabetes, sleep apnea, tobacco use, alcohol, all of those things. Add TBI to that list. So if somebody's had a brain injury, they're at the highest rate of having a stroke within the first month after that brain injury. That said, that risk doesn't go away. In the research that I looked at, there was still an 8% increased risk at 5 years post brain injury for someone to have a stroke. So for up to 5 years still, they're at a pretty high risk of having a stroke after their brain injury because of the damage that's been done. So a lot of other statistics that I looked up. So in a study that was done on Medicare patients, the rate of a hemorrhagic stroke, so bleed into the brain, was 10 times higher after a TBI than somebody who didn't have a TBI. So they did those comparisons. In patients that have severe traumatic brain injury, when they are admitted to an ICU, they have greater than a 40% mortality rate when they have a stroke after that brain injury. So admitted to the ICU with that brain injury, they have a stroke, greater than 40% rate of death at that point. If they're in the hospital, but they're not in the ICU, so they're not quite as severe as that first group, there was still greater than a 10% mortality rate when they had a stroke after that brain injury. So again, hospitalized, not in ICU, have a brain injury, and then they had the stroke, still that greater than 10% mortality risk. And then they looked at patients that had a stroke history. So if they had a history prior to their brain injury, had the brain injury, and then they had another stroke afterwards, they also had increased mortality beyond these numbers. So that mortality just keeps going up if you have one brain injury and then another right afterwards. In the trauma population, so patients that come in after motor vehicle accidents or some other kind of trauma, traumatic brain injury was actually responsible for more strokes than hypertension, which is kind of a big deal because hypertension is one of the biggest risk factors in general for stroke. So for brain injury to be more related to those strokes than hypertension is even a bigger thing right there. And then regardless, when we're able to control for other variables, meaning we have patients that are similar age, gender, ethnicity, we're looking at similar other risk factors that they have. In general, when we can control for all of that, we have the same kind of populations that we're looking at, there are worse outcomes overall for someone that has an acute stroke after their brain injury than if they just had the brain injury alone. So that's also just a big deal for recovery right there. How does TBI increase the risk? So the exact mechanism is unknown, but there are theories behind it. So some of those theories include alteration in the coagulation cascade. And basically that's fancy terms for the series of steps that are required to create a blood clot in the body. There's a whole cascade of hormones and responsibility in the body that creates a blood clot. There are alterations in that cascade after a brain injury for some reason that puts the person at higher risk for forming clots that then lead to a stroke. Another theory is the disturbance in the blood supply from the injury itself, whether it be from edema and swelling on the brain or just the shock of the injury itself causing obstructions in those vessels. That can then increase the risk of stroke. Because again, if we have an obstruction, whether it's from swelling pushing on those blood vessels, there's an obstruction of that blood flow, and now we end up with a stroke after that. Another theory is vascular dissection. So when we have a dissection, that means that there's a tear in the inside layer of that vessel. So when we look at blood vessels, there's an outer layer and there's an inner layer of those blood vessels. And that just helps at all levels. It helps to keep those vessels a little bit more secure. But when we have a sudden movement with trauma, one of those, it's called the intimal layer. That's you kind of think of intimate, a very, very small layer on the inside of that vessel gets torn. And we end up with what's kind of like a little flap that is sticking off of that vessel. And that is where red blood cells and platelets will tend to clump on that little flap and try to correct it and heal it like they would cause a scar on the skin or a scab on the skin. They're trying to cause a scab and close up that tear inside the vessel. But that can block the vessel, or those little clumps of platelets and red blood cells can break off of that and go downstream and cause a stroke. So that's another theory. Another theory with it is increased intracranial pressure and hypertension. And increased intracranial pressure just means that inside the skull, we don't have a lot of exits for things to move. So if the brain swells, we end up with higher pressure inside the skull because we don't have a lot of exits out of there for the brain. And when we have high blood pressure, that creates more pressure inside the brain. So that's another theory, is that just we have that increased pressure and that causes blockages and compression of vessels, and that can potentially increase the risk of a stroke. And then finally, the last theory on this is just because of a brain injury, partly we're telling people to relax and try not to do too much because they need to recover and they need to heal. But in doing so, we're also creating a more sedentary lifestyle for that patient. So for whatever length of time they're trying to heal from that brain injury, they're more sedentary. They're not getting up, not moving around. And that can increase the rate of those conventional risk factors that we talked about, the high blood pressure, high cholesterol, diabetes, yada, yada, all of those, because the patient is no longer moving and active and their body is responding differently. So interestingly enough, when I was preparing for doing this presentation, and I prepared for months before actually giving it the first time, we had a patient come in who came into our emergency room with symptoms of a stroke, was concerned that he was having another stroke. Upon talking with him more, he had a history of multiple concussions while playing football in the early 2000s, causing him to stop in 2008. So he had no longer been playing, and this had been about 8 years now, or 10, excuse me, about 10 years now, to the time when he stopped playing to the time that he came in. Currently, when he came in, he was 39 years old. So he was very young when he stopped playing football because of all these multiple concussions. While he was still playing, he had the development of what we call ocular migraines. He had problems with his vision leading to migraines. He didn't necessarily have full-on head pain, but he had problems with vision while he was playing football. He went in, he got seen by a neurologist. They did an MRI of his brain. He had these scattered lesions in his brain. Lesion is just a fancy term for a spot in the brain that we don't know exactly what it was. Sometimes these little tiny lesions can show up, and they can be common in patients that have high blood pressure. It can be common in patients that have migraines in general. He was told this was, quote, common for patients or people who were football players. So thought nothing of it. They gave him some medications for the migraines, told him to keep playing. 2 years after he stopped playing football, he had multiple territory strokes, meaning multiple blood vessel areas in the brain were now affected by little tiny strokes. So about age 30 is when this all happened. He had an extensive workup, and no cause was ever found for his strokes. So he was very anxious about the fact that he could have another stroke at any time, and he didn't know why he had had all of these strokes to begin with. So just to kind of give you an idea, when somebody comes in and they are a young patient, so typically less than 50 years old, we have an extensive workup we do. We look for problems with coagulation, meaning genetic issues that might lead a patient to have more risk for forming clots. We look for openings in the heart that might cause blood clots to transfer from one side of the heart to the other when they shouldn't be there. We look for all sorts of different things to try to figure out why a young patient might have a stroke. When we have somebody that has multiple territory strokes, so we have strokes throughout the brain, that's another level of testing altogether. Now we're looking at their heart to try to figure out, do they have something structurally wrong with their heart that's causing them to have strokes? Do they have an irregular heart rhythm? You've heard on all the commercials, atrial fibrillation can cause strokes in multiple areas of the brain. So he had all of this workup. And oddly enough, he had just stopped. He was getting set up with a new healthcare provider, and he had just picked up all of his healthcare paperwork and had his medical records with him. So we got to look at all of these results for all of the testing that had been done and done again, trying to figure out why he'd had a stroke, and he'd never had an answer for why he had the stroke. So if I were doing this presentation in front of you, I would have pulled up all of his MRI images because it was really cool, but I'm going to count these out for you. So 1, 2, 3, 4, 5, 6, 7 different areas in both sides of his brain, in multiple vessel areas, that he had these little tiny strokes. Nothing was ever really big, thankfully. So he didn't really have on his exam, he didn't have any limitations that I could see. So no weakness, no sensory changes, no vision, language, anything like that. But he had all these old spots on his brain. Thankfully, he didn't have any new spots on his brain. So when he came in, even though he was afraid that he was having another stroke, there was not evidence of a new stroke on his brain. Essentially, he was having a panic attack because he was so scared of when he was going to have another stroke because the cause had never been found. Now, that said, about 15 to 20% of all strokes go without a known cause. We do extensive workups on everyone, and we don't always find a cause. But he did feel a little bit of comfort knowing that, funny enough, as I was going through this research, I shared all this research with him to let him know that this could have been an increased risk for him just having all of those head injuries, because when he had all of those strokes, it was still just a couple of years after he'd had all of those concussions. So that was a fantastic time for him to come in for my research, but it was a good conversation that we had to try to figure out what was going on with him personally. So I love teaching my patients. I love going through their risk factors and trying to help them figure out what's going on and why they had something happen. So this was perfect timing so that I could put those two together and actually give him a little bit more information on why he might have had a stroke. So for the practitioners in the room, what do we do about acute interventions. So when we look at, there's a medication, it was called Alteplase before, now some places are using Tenecteplase. Regardless, it's a clot busting medication to break up the clot that's happening, that's causing the stroke symptoms right now, so that we can try to reverse as much of those stroke symptoms as possible and potentially knock out the stroke completely. There is a list of contraindications for that medication. So even though somebody comes in with stroke symptoms, it doesn't mean that we can automatically give them that medication, because there are some things that say, hey, you know, there we will have some hard stops saying, nope, if you have this, then we cannot give you that medication. Serious head trauma is listed as a relative contraindication, meaning the provider that's seeing the patient has to determine the relativity of that contraindication. I will say that clot busting medication is considered gold standard, meaning if you come in within the time frame and you have stroke symptoms and we can rule out the fact that you're not having a bleed on your brain, we should be giving you that medication, because that is tried and true. We have the best outcomes with patients when they get that. But when we have something that's a relative contraindication, we do have to take a step back and think big picture. Is this worth the potential risk that's there? But we do a lot of discovery in that and try to figure out which, in this instance, which came first, the serious head trauma or the stroke, because sometimes the stroke may have immediately preceded or precipitated the traumatic brain injury. So they might have had the stroke that caused the brain injury to begin with. And I actually had another example of that as well. A 57-year-old female that we had come into the emergency room. She'd been in a motor vehicle accident. So her car was seen going down into a ravine. She hit a tree. The airbag in her car did not go off. The car windows were not broken, which indicated that it was probably a low speed car accident. But EMS, the paramedics were called within minutes, thankfully thanks to a bystander that saw the car go down into the ravine. When the patient came to the emergency room, she was able to describe the fact that right before the crash occurred, she had a sudden left-sided numbness and weakness in her body that caused her to lose control of the car. So the stroke happened before the motor vehicle accident in this setting. So for this patient, the discussion was had, and it was determined that, yes, so head imaging happened. So she didn't have a bleed on her brain. She had no damage to the brain that was able to be seen on that head CT that we did in the emergency room. So the decision was made to give her the clot busting medication. And she actually had a blockage of one of the vessels. So there's another treatment we can do called a mechanical thrombectomy, where we go up through a vessel in the groin and kind of snake a catheter up there, and through the catheter remove that blockage of the vessel. So she got both the clot busting medication and that mechanical thrombectomy to remove that massive clot that was in her vessel. And we were able to treat her so that her stroke went away. So we prevented the stroke from actually occurring because she came in so quickly and we identified it so quickly. By the time she left our hospital, the occupational therapy assessments identified cognitive impairment, probably related to the concussion, and she had nothing related to the stroke anymore at that point. Again, this would be the point in time where I would pull up the imaging for you. We did what we call perfusion imaging prior to her interventions. So perfusion imaging is a colorful image that shows us where the blood flow is in the brain, and almost the entire right hemisphere of her brain. So the right side of the brain controls the left side of the body. She had left-sided weakness and numbness that occurred because of the stroke that was trying to happen on the right side of her brain. And it was the right side of her brain where the MCA, the biggest vessel that feeds that right hemisphere of the brain, was blocked. And the clot busting medication, the mechanical thrombectomy, the removal of that clot opened that blood vessel up so that her MRI after the treatment was done showed no evidence of stroke. So we completely reversed what would have been a massive, devastating stroke for this patient, because we were able to identify the stroke happened before the brain injury. She was having a stroke and we treated it. It was really an exciting time in that emergency room. So shifting gears, what if something else happens on the brain? If we have illness happen on top of a brain injury, just by means of having that brain injury, patients are at increased risk for falling, as we talked about, which also puts them at increased risk for osteoporosis. So when they fall, they can have a fracture. They're at increased risk of pneumonia because of changes on the brain. If any of those happen, or if a patient has surgery or some sort of procedure that requires sedation, or they end up with some sort of infection, even other than pneumonia. Remember back a little bit ago, I talked about that part-time job of those cells around the stroke area that pick up that part-time job so that the patient can regain function. Well, when something like that happens, either surgery, sedation, infection, something like that happens with the brain, then our brain reverts back to full-time mode again and takes away some of that part-time job. So during those times, their patient's recovery takes a setback. People start to get concerned that they're having another stroke because their symptoms have come back. There's a fancy term that we use for that too called recrudescence, meaning that because of something else that's going in the body, the infection, the surgery, whatever, they had a resurgence of their old stroke symptoms that will then fade away again once they recover from that new insult that's happening, because sedation is still an insult, whether it's necessary or not. But when somebody has all of these other things happen, they fall, they have fractures, they get infections, they have something else happen in the brain, they get some sort of other illness that does affect their outcomes. And we do generally see a decline in their outcome. We see a decline in their function. We see a greater chance that they don't get back to that original baseline again, and they now have a new baseline that is set. So lots of things come into play when we have multiple brain injuries, multiple other things happening in the body, that our brain just can't take it all and constantly keep going at full speed. So we have to take a step back. So to kind of wrap up a lot of things that we've talked about today, I covered a lot of information, but in general, I just want to kind of leave you with these thoughts again, that stroke and brain injury are interchangeably risky for one another. We can see one causing the other or leading to the other one at fairly high rates on these. And having both of those increases the disability and worsens the outcome for a patient. That said, therapists are our best friends when it comes to recovering from either kind of brain injury, whether it's a traumatic brain injury or stroke, and even more so are our best friends when we've had multiple issues occur and the brain has to recover from all of that. So again, occupational therapy, speech and language pathology, physical therapy, all of those are going to be really important based on what kind of symptoms the patient is displaying after their brain injury or stroke. Or both. And then because I'm a runner, because I do all of that, I'm going to put this at a level that some of you might think of a little bit more. When we recover from these things, we recover from multiple brain injuries, this is like marathon level training. This is not going to be the sprint recovery. We're not going to do that quick little 50-yard, 100-yard dash and be done, and our breathing is high for a few minutes and then we calm back down again. This is marathon. It's hours of running that translates to years of recovery. Brain injury is not even though some people kind of get back to normal fairly quickly, not everybody will have that quick of a response. And it can take years or more for people to really kind of feel like themselves again afterwards. So just give yourself grace. And wanted to close with just a few more things on this. Some good rules for recovery when you have had a stroke or a brain injury. First off, I'm gonna give the caveat that these are things that we should all be doing anyway. So do all the things that we should already be doing. And that includes things like regular sleep and rest, going to sleep at the same time, waking up at the same time, regardless of what day it is. Don't have a TV in your bedroom, all of those things. Getting good regular sleep, listening to your body. When you're in that acute recovery, meaning the first few weeks after the recovery, sleep is good. I will give my patients prescriptions for sleep if they need to. And I've had to have to do that a couple of times when people said, oh, I just can't. And I'm like, okay, if I put it on a piece of paper and give it to you, will you actually listen? Because you need sleep. That's when your brain recovers the most. So regular sleep and rest, very, very important. Nutritious food intake. I had a conversation with someone recently and I said, eating good foods. And they're like, well, what exactly does that mean? It means that you're eating mostly whole foods. So whole, real foods, vegetables, fruits, healthy meats, healthy fats, avoiding the processed foods, avoiding things that are going to be highly sugared, highly processed, have a lot of chemicals in them, because those chemicals are going to make it difficult for your brain to recover as well. Having good hydration, and that means drinking in general about half your body weight in ounces of water. Unless you have a heart disease that says you can't drink that much water, you should be getting that much water on a daily basis. What counts for that? Any liquid, clear liquid that doesn't have caffeine in it. So herbal teas, water, even if it's flavored water, just try to avoid the artificial sugars with it. Okay. Coffee does not count, regular coffee, because it's caffeinated, and caffeine actually dehydrates you. So try to avoid that one. Stress reduction. Again, I've talked about this in other episodes. Stress is not going away, but you need to try to control for it. So working with a therapist, working with your family, do whatever you need to do so that you can reduce that stress, especially during that acute time when you're healing, so that your brain can actually recover. Social interaction. People don't often think about that. I don't want you to go out to parties if your brain is trying to recover, but do interact with other people so that you have those social cues. You have reasons to keep your brain thinking about things, because your brain is a use it or lose it type of thing. If you're not using it for social interaction, you're going to lose some of those abilities. And then regular exercise. And I'm not saying go out and run a marathon at this point. When you're trying to recover from a stroke, it could be as simple as a stroke or brain injury, going for walks. And again, not long walks. You're going to start with walks around the block. You're going to start with short things and kind of increase from there, but making sure that you're staying safe while you're doing that as well. Be with other people when you're exercising, so that if you do start feeling lightheaded, dizzy, or anything, somebody can help you. As far as those are things that you should do, the next set of things is going to be things that you should stop doing. I want you to quit the bad habits. So tobacco use, excessive alcohol, neither of those things are going to be good for your brain. Both of those are going to put you at increased risk for having other things happening. So when you're trying to get your brain to recover, you need to put those things on the back seat and ideally never pick them back up again. So quit those bad habits so that your brain has the highest chance for recovery. And then, especially during that acute time frame, reduce all the things that take a lot of brain power. The biggest thing in here is screen time. We live on our computers, on our phones so much these days. It takes a lot for our brain to take in all of those visual cues. It takes a lot for our brain to focus on those screens and those colors on the screen. So reducing that screen time. You know, the American Academy of Pediatrics says less than 2 hours of screen time for kids. That's that same kind of thing for somebody that's had a brain injury. You should be spending less than 2 hours on a screen in a day for at least the first few weeks after a brain injury or a stroke, so that your brain can actually heal. So I used a lot of references when I initially put this presentation together. I will include those references in the show notes so you can see all the references that I used. But if you do have any questions or comments on this information, on this particular topic, or you have requests of other topics that you'd love to have me do some research on and present like this, please send me a note. My email for this is brainwellnessnp at gmail.com, or you can find me at www.brainwellnesssolutions.com. There is a contact me section at the bottom of the page there as well, and you can send me a message there. So thank you for listening today, and I hope you have a great rest of your week, and I will see you back on the show next week. Thanks, guys.